Dean for the Public Health Programs at Washington University, and it is my pleasure to welcome you to our March installment of Public Health Speaker Series. Before we begin and before I introduce our speaker for today, I just want to give some reminders to please try to keep yourself on mute if you are not talking during the presentation. We'll take questions towards the end, and you can do that by putting your questions in the chat, or when it's time for questions and answers, please feel free to come off mute and ask your question out loud as well. So with that, I'm going to go ahead and introduce our speaker for today. We have the distinct honor of having Dr. Fred Echols join us today. Dr. Echols is the director of the Department of Health for the City of St. Louis. He has earned a medical degree from Boston University in Boston, Massachusetts. He completed postgraduate training with the United States Navy in Portsmouth, Virginia. And during his military career, Dr. Echols served as the primary medical officer for Marine Aviation Logistics Squadron 16 in Miramar, California, and the lead medical provider for Camp Bastion during Operation Enduring Freedom, and as a member of the Aeromedical Advisory Board. After completing his medical military service, Dr. Echols served as the chief of communicable disease for the Illinois Department of Public Health and the director of communicable disease control services, vector and veterinary programs for the St. Louis County Department of Health. And as you all can imagine, Dr. Echols is probably extremely busy these days with the COVID response for the city of St. Louis, among his other duties. So it is quite the honor for him to take his time to be here with us today. So without further ado, please help me give a warm virtual welcome to Dr. Fred Echols.
Angela, thank you for that introduction. I'll start to share my screen now. All right, thank you all for this opportunity. I know that you all are busy as well. And so with COVID-19 impacting essentially everything that happens in the city of St. Louis, I'm grateful again for this opportunity to share some information with you. The focus of the presentation today will be on re-envisioning public health practice, which I think the timing is very, I couldn't have asked for better timing, especially with the amount of federal funding and additional allocations that jurisdictions across the world are receiving to improve public health practice. But there are some challenges that have been in place for quite some time. If you look at trends, which we'll discuss a little bit during this presentation, at least in the United States, we have a tendency to forget lessons learned, especially during disasters. And so the City of St. Louis Department of Health is working to ensure that lessons learned during the COVID-19 pandemic are not lost. I have no conflicts of interest to declare. The mission and vision really established the cadence of the City of St. Louis Department of Health. As stated here, our mission is to assure a healthy St. Louis community through quality public health services and partnerships by providing continuous protection, prevention, and promotion for the public's health. And our vision for the City of St. Louis is an equitable community achieving optimal health for all, which means that we really have a focus, not only health equity, but health justice. For this presentation, it is a hope that the attendees will be able to have a better understanding of the origins of public health practice, understand some of the evolution of public health practice, also understand historical trends of inequities and their impact of health outcomes in the United States, particularly among disenfranchised and minority populations, recognize the importance of following post-pandemic and post-disaster recommendations issued for public health, and to recognize the potential benefits of integrating intersectionality analysis into public health practice. The history of public health is a narrative that entails individuals and groups seeking for an effective means of protecting the health of a particular population. It's derived from many historical ideas, trial and error, the development of technology and basic sciences, as well as epidemiology. In the modern day era, James Lynn's clinical trial of various dietary treatments on British sailors with scurvy in 1756, and Edward Jenner's 1796 discovery that cowpox vaccination prevents smallpox have modern day applications as the sciences of practices of nutrition and immunization are crucial influences of health among the population across the world. However, history provides a critical context and perspective to develop an understanding of health problems and communities and how we cope with them. But along those lines as well, it's really important for individuals to understand that public health is not static, it's extremely fluid, and it continues to evolve. And I think the activities of the COVID-19 pandemic have really highlighted that, especially when we look at what has happened with vaccine development and how we've been able to develop vaccines in a much timelier manner than they were able to do in the past due to technological advancements as well as medical advancement. And public health practice is a very broad term, but overall it's deemed to be the work of public health professionals impacting people every day in every part of the world. The conception of public health extends to societal activities well beyond those performed by governmental public health authorities. Protecting the public's health, however, is a quintessential function of government. The focus is on those activities of federal, state, and tribal and local public health agencies and their authorized partners. And even when confined to government, public health practice is extremely broad in scope. In fact, most public health practices feature voluntary cooperation of individuals, which includes, for example, performing contact tracing for COVID-19 cases, tuberculosis cases, as well as other communicable diseases, obtaining food histories in the face of a common source outbreak, or administering testing or screening programs. Just as in the private medical sector, evaluation activities are conducted by public health practitioners to assure quality of care and program effectiveness. However, as we evaluate our programs, it's also important to document lessons learned to ensure that we don't repeat previous mistakes. Historical trends is something that we always need to be mindful of. And there's one statement that was in an article that was published in 2018 that says, racial ethnic minority populations experience worse health outcomes than do other groups during and after disasters. This is primarily due to disparities in communicable disease exposure, disparities in susceptibility due to underlying medical conditions, and disparities in access to healthcare, which again leads to disparities in underlying medical conditions and treatment, as well as a greater social risk with less ability to undertake pandemic interventions. Now I'm going to talk about some of the disturbing trends that we've seen. And so the graph on your screen goes back to 1900. And so if you go back to the beginning of 1900 all the way through 1996, the all-cause mortality, when you look at white and non-whites, shows that non-whites have been disproportionately impacted by essentially all causes of death. There is a slight blip around 1918, and that's due to the 1918 influenza pandemic that impacted the city of St. Louis as well. And but what we've seen, so in spite of what happened in 1918, non-whites have been disproportionately impacted by all causes of mortality. And although the margin has narrowed over time, there's still significant progress that needs to be made to close the gap between the health outcomes related to health outcomes of non-whites and whites. And I think when we look at this graph as well, so although the pandemic in 1918 shows a slight blip. The fact that it goes, it's not only attributed to that particular event. The sustained gaps in influenza and pneumonia and influenza mortalities were evident again before and after the pandemic influenza event in 1918. Of interest here, so similar to what we saw in the other slides, so there was significant disparities or significant gaps between health outcomes for whites and non-whites. Particularly in 1950, the age-adjusted pneumonia and influenza mortality rate per 100,000 persons was reported to be roughly 76.7 for African Americans and non-whites, and roughly 44.8 for whites. And again, although we've made significant strides to narrow that gap, we still have a significant way to go. This is another graph that looks at essentially it's a reflection of access to healthcare. And so what we see here is that when we look at vaccination coverage or vaccine coverage going from 1989 through 2005, whites had a higher percentage of individuals that were covered among 65 years and older by race and ethnicity compared to other populations, particularly the non-white population. And this is something that continues to, we continue to see year in, year out as we look at public health data related to influenza and other vaccine preventable diseases. It's also important to note, so although we see those trends that have occurred from the early 1900s to the 2000s, several other significant public health events occurred during those times, and some of the recommendations that were made after the disasters are listed here. And so if you read these, you'll see that a lot of these are very similar to similar recommendations that have been made during the COVID-19 pandemic, such as making sure there's culturally competent preparedness and response that addresses specific needs of racial and ethnic minority populations, improvements in public health and community health safety net systems, such as our federally qualified health systems, health centers, as well as Medicaid, Medicare, public insurance option providers, and other resources. Along those lines as well, making sure that social policies that minimize economic burdens to improve compliance with isolation and quarantine are recommendations that we also made during the COVID-19 pandemic, and also relevant, practical, and culturally and linguistically appropriate tailored communications, particularly for non-English speaking communities and immigrant communities. And ensuring that undocumented immigration status does not present a barrier to health care of immigrants. And so as we are actually rolling out the vaccine, this COVID-19 vaccine in the city of St. Louis and other parts of the state, this is an area of concern, particularly for undocumented immigrants. And last but definitely not least, include race and ethnicity data in public health and hospital reporting. And this is really important. So as we've looked at the reporting that has occurred in the United States, going back to August of 2020, at that time, roughly 6 states in the United States were including race and ethnicity data in their public health and hospital reporting related to COVID-19. And most recently, I believe it's been reported that only 18 states across the United States were including race and ethnicity data for public health and hospital reporting. And although you have that happening amongst 18 states, even within those jurisdictions, you don't have standardized reporting and standardized data collection amongst public health agencies and hospital agencies, which creates extreme challenges for health departments that are attempting to use the information to guide public health practice. And so knowing those challenges, data collection, having these histories of trends of certain populations being disproportionately impacted, The examples provided were for influenza and pneumonia. However, when we look at other reportable conditions, whether sexually transmitted infections, foodborne illness, and other issues of public health concern, there's significant opportunities for advancement to improve how not only we collect data, but how we use the data to address the root causes of the inequities and disparities that we see. And so next we'll talk a little bit about reporting and analyzing data. So in the United States, we typically look at, we get case reports and then we disaggregate data and we look at each particular issue, whether it's an individual's ethnicity, their income, their education, and we evaluate that separately. And when we do that, we essentially evaluate the information in a silo. And so when you evaluate the information in a silo, your perspective and your ability to analyze and make connections to other issues is extremely limited. And so one of the things that has come to light, not only in public health, but in other social movements, is the need for intersectionality. And so one of the things that we found was that, when we look at, when we analyze data in silos, it's insufficient for getting an intersectional analysis. And so we are typically unable to describe why identified disparities exist, and it implies that the source of health inequities lies within the specific individual or groups who bear the burden, and suggests that poor health is an innate quality of certain groups rather than created and maintained by systemic oppression. As a result of this improper understanding of health, health authorities develop interventions for focused populations and disregard the structures and systems that perpetuate racism, providing advantage for some while disadvantaging others. And in order for us to move the needle, we must look deeper to understand social and demographic data as a representation of the impact of interlocking and intersecting systems of oppression. And so we can't talk about that without talking about intersectionality. And so if we're going to talk about intersectionality, we have to talk about this one lady on the right, who is Kimberly Crenshaw, and the other lady in the other group on the left, which is the Combahee River Collective. And so these, the Combahee River Collective and Kimberly Crenshaw issued statements about the need for intersectionality and how some groups, although have a similar focus, they can still be left out because of the inability to identify and connect different systems of oppression that are working against one particular group, although the cause is for a much larger group. In particular, the Combahee River Collective statement was created by Afrocentric Black feminists who parted ways from the National Black Feminist Organization in order to create, define, and clarify their own politics. And these were women who actively committed to struggling against racial, sexual, heterosexual, and class oppression. And it was their particular task to further development of integrated analysis and practice based upon the fact that the major systems of oppression are interlocking. To this specific group of women, the National Black Feminist Organization is a coalition that they believe in, but did not recognize or address Black lesbian feminist politics and system of oppression within their group. And put simply, when we look at intersectionality, so intersectionality is the concept that all systems of oppression are somehow connected. More explicitly, the Oxford Dictionary defines intersectionality as the interconnected nature of social categorizations such as race, class, and gender, regarded as creating overlapping and interdependent systems of discrimination and disadvantage. Intersectionality forces us to acknowledge that everyone has their own unique experiences of discrimination and oppression, and we must consider everything and anything that can marginalize people, which includes gender, race, class, sexual orientation, and physical ability. To create lasting change, public health and health authorities must be willing to confront the source of inequities and use intersectional public health responses to do And in order to do this, we must consistently collect information that will facilitate the identification of inequities across multiple axes of oppression. And this is really why how we collect data, but also the quality of the data that we collect is extremely important. And this next diagram is the previous diagram put in a different format. And so what this shows is that intersectionality is a contextual framework for examining how the systems that are intertwined to cause oppression influence experiences and opportunities. As shown in this diagram, the systems that shape experiences cannot be separated. And although this is what we typically do when we look at only an individual's race, or we don't look, or we tease out only their economic status or their education status, it prevents us from actually looking at how the systems operate and how they function together as a collective to perpetuate oppression amongst certain groups. And even though they are, again, although they're studied that way, that's not ideal. And so that has essentially hindered public health's ability to gain ground on addressing the inequities and disparities, again, that have been in place for over a century. And I guess a good example for this would be, an African-American woman with a disability does not just walk through life only as a woman, as an African-American or a person with a disability, but instead through her own unique interaction with the systems in which she is situated. Intersectionality deepens the understanding of and ability to improve the real life experiences of marginalized groups. And although intersectionality has most recently been brought to the forefront of research, particularly social movements, and it still has not necessarily made its way into public health, which is again why this time is really necessary. So in 2015, the term intersectionality was finally put in the Oxford Dictionary, but still there's still a lot of hesitancy to adopt this particular paradigm because of the challenges that it presents, not only to particular organizations, but it presents challenges for systems at large that actually perpetuate the oppression that we often talk about. And although it hasn't necessarily been widely adopted in the public health sector, as well as in the hospital sector, in the United States, there are some studies that have utilized this intersectionality, intersectional analysis to look at the impact of these systems on individuals' ability to maintain proper health. And this is a study that was done in Indonesia. And this is a study that was done by Re et al. And what they found was that 90% of respondents reported stigma experiences owing to their health condition. Gender and socioeconomic statistics were the most reported social inequalities that intersected with the experiences of health-related stigma. In the study, they reported multi-level intersectional experiences, one at the macro level, which was described as exclusionary policies and practices in healthcare settings and workplace and oppressive social norms in the Indonesian society that devalue and discredit people based on the different social inequalities, oppressive identities they hold in conjunction with their health condition. At the meso level, which is the interpersonal level, some people reported experiences being stereotyped, judged, and discriminated against by societal actors, which includes healthcare providers, employers, and work colleagues, neighbors, and family and friends. And at the micro level, which is the intrapersonal level, individuals reported that their experiences at the macro and meso level impacted their self-esteem, shaped their personal experience of stigma onto their health conditions and the different identities they bear in the form of internalized guilt, shame, and fear impending negative judgment and discriminatory behaviors from others. And although this was done in Indonesia, a lot of the reports that we receive as a health department from individuals in our community reflect these same ideals and these same experiences that were shared in this study. So integration of intersectionality. So how do we in public health adopt intersectionality into public health practice, and what does that look like, and when is it really necessary? And so when we look at intersectionality, it's really necessary if we look at the trends in public health and we look at the trends in health outcomes going back to the 1900s. A lot of the issues that our predecessors faced are still present today. There have been several recommendations during intra-disaster and post-disaster recommendations that have been made for health systems as well as public health systems that have not quite been adopted in a way that's sustainable over time. However, when we look at implementing a intersectional approach, that allows us the opportunity to really better understand how systems operate, and then we can do a better job of addressing the inequities and disparities that we talk about on a day in and day on a daily basis more effectively and in a sustainable manner. So in order for the public health agencies to integrate intersectional approach to public health practice, there are a few things that we have to do. So one, we have to understand the history as well as the definitions of intersectionality and what that actually, and how, and to make sure we're using it in the proper context. We also have to work to understand the current state of systems and structures of power. As I tell my staff, we have to make sure we understand the system so that we don't eventually become a part of the system that perpetuates the same ideals that we say that we're trying to address. So the inequities, the disparities, the racism, the stigma that our community often experiences, and the manifestation of that is the inequities that we see and the disparities that we see on a yearly basis. And also have to assess and evaluate data collection efforts. So as I mentioned before, even with COVID-19 and other reportable conditions, there isn't, data collection has not been streamlined in an efficient and effective way to ensure that we're collecting the information that we need to make the decisions, the decision necessary to improve the health of our communities. Intersectionality research. So this is also really important. So intersectionality research is inchoate, to say the least, especially in public health. And so to really explore this much further is going to require additional funding, additional advocacy to ensure that public health agencies and public health professionals can properly conduct qualitative and quantitative intersectionality research, which can be used ultimately to improve health outcomes in our jurisdictions. And then use of intersectionality as an analytical tool. So making sure that we can use the information that's collected in the proper context, as well as making sure that we can properly determine what the research findings are actually telling us and how we can apply those findings to issues that we're seeing in our community. And then practical application. We need to make sure that however we use intersectionality research can be, the application can be practical and meaningful. If it's not practical and meaningful, then it's essentially a waste of resources. And so one way of doing that would be, for example, using structural equation modeling to make sure that we are properly capturing and analyzing information related to the systems of oppression that we're trying to address. And ultimately, intersectionality does not assume that knowledge for knowledge's sake will resolve public health crises, but demands that we reimagine the intersectional praxis to solve them. And ultimately, our ultimate goal, our ultimate intended outcome is for health justice for everyone. And that means that we are proactively working to not only connect individuals to resources, but that we're also actively working to remove any barriers that may be present that may prevent individuals from achieving optimal health. So now I'll turn it back over to Angela.
Okay, thanks so much, Dr. Echols. And we have plenty of time for some questions, comments. So I encourage anyone who's attending to please either put your question in the chat or to feel free to come off of mute and ask your question directly to Dr. Echols.
I'll jump in. My question is on, I'm a health policy student here, and we talk a lot about federally qualified health centers and the need to fund them, and increase resources available at them because they're so important for vulnerable populations. And locally in St. Louis, I'd love to hear your take on what the challenges have been to federally qualified, St. Louis is federally qualified health centers as a part of COVID, because I imagine it's not the same as what affected the big hospital systems.
So I think that there has been some overlap. So with the federal qualified health centers, so one, I think understanding the bigger picture is related to health for indigent populations in the city of St. Louis. And so over time, a lot of the resources that were once in place were removed because there wasn't good planning, and good planning wasn't conducted. And so a lot of the resources, so we look at, when we think about a lot of the hospitals that were in minority communities, those are no longer present. When you think about resources that the health department used to have, we used to have our own clinic, primary care clinic, immunization clinic. Those resources are no longer available because a lack of advocacy on behalf of local government. And so for the federally qualified health centers, particularly for COVID-19, they've really been the saving grace for the city of St. Louis. Again, because a lot of the resources that were stripped away from the health department, and just to give you, allow you to scale this in your mind. So roughly 5 to 10 years ago, the health department, the City of St. Louis Department of Health had roughly 450 to 500 staff. At the start of my tenure in 2019, there was less than roughly 85 or less staff in this health department. And so we think about having the capacity to actually do this critical work we call public health. The capacity was not there. There was no work for it. The workforce was insufficient. Professional development for staff had not taken place, and so there was a lot of work that we had to do. And luckily, COVID didn't happen right at the start of my tenure, but I had about a year to really get things under my wings. But then COVID happened, and everyone was, I guess, taken off guard. No one expected the pandemic to happen, but we also had to be mindful of what resources we had in place. And so being familiar with the system was really important for me. So knowing that the federally qualified health centers, is a system that was in place and that was still functioning, that could provide quality medical services and culturally sensitive and culturally appropriate medical services for our most vulnerable populations was really important. When we look at what happened at the very beginning of the pandemic, minority populations were the hardest hit. They were disproportionately affected by COVID-19. The first 13 to 15 deaths were African-American, elderly African-Americans with underlying medical conditions. But then the wave of COVID-19 or SARS-CoV-2 kind of swept across the northern part of the city. And that really took out a lot of our most vulnerable individuals, our most vulnerable populations. And so what we had to do at that time was invest in those areas that were considered to be have the highest level of poverty, have the highest percentage of individuals who are uninsured or underinsured, and the individuals with the highest level of health illiteracy, to make sure that they not only had information, the knowledge to actually implement the mitigation measures that we were talking about, but they also had the resources. We worked with community partners across the city, including the regional response team and a few other groups, to actually canvass those areas to make sure that they had the resource, the information. But one individual reached out to me when I was out canvassing, and they said, the information is good, but we need resources. And so then going to the local, the neighborhood store and seeing that they're requesting for people to pay $12 for a face mask when people can barely cover their rent and put food on their table. That was not accessible. So what we did is we worked with the federally qualified health centers and other partners to give resources out into the communities so that they could have the tools that they needed to protect themselves. And what we saw as a result of that was roughly a 33% increase in the number of COVID-19 cases across the city, across the northern part of the city. If you take a look at our annual report, what you'll also find is that as we move through the second and third wave of COVID-19 in the city of St. Louis, the majority of those cases were in South City, which are typically where we have higher individuals, higher income level, higher education attainment, et cetera. And so investing in our most vulnerable populations pays dividends in the end. And so that's one of the lessons that we've learned. But back to your original question, the federally qualified health centers play a critical role in making sure that our most vulnerable populations have access to resources and services. We couldn't have gotten to where we are without the federally qualified health centers. A lot of them have hosted community testing clinics. They're also doing community vaccination clinics to help make sure that every individual has an opportunity to receive these critical resources.
Great, thank you so much. And thanks, Malcolm, for that question. And we have a couple that have been in the chat. Another one from Malcolm about if you have some specific examples of how Department of Health programs or initiatives had to adapt due to shutdowns, and what are some things that you're hoping to ramp up after the pandemic is under control.
So several of our programs initially had to pivot. So as I mentioned before, we had roughly less than 90 staff at the start of the pandemic. And so one of the things that everyone heard was about contact tracing. We need so many number of contact tracing. The National Association for City and County Health Officials put out their recommendation based on population size, but then that didn't take into account the utilization of technology and so forth. And so there was a lot of political pressure that the health department had to endure during that time. And so what we did was we streamlined our processes. So we made sure that we were able to utilize the technology platforms that were in place to assist with contact tracing efforts. So for example, typically if you're doing contact tracing the old school way, what you'll do is you have someone calling the individual every single day, getting their information. And that just wasn't feasible. You have 85 staff and that's covering all public health programs. That's just not feasible. And so we utilize Qualtrics, the Qualtrics platform, and to send individuals who are under quarantine, we send them those notifications each day. And they were able to communicate to us via text or via email, their temperature, if they have symptoms, et cetera. And so we're able to monitor them that way. And then for individuals who did not have access to technology, we actually had staff calling them. And so we still had to implement the traditional contact tracing efforts because of the digital divide that also exists. And we actually saw that worsen a little bit during COVID-19 because a lot of individuals lost their jobs. When we published our registration database for COVID-19, we actually started looking at that data. And what we found was similar to what happened in the beginning. So the individuals in North City were disproportionately impacted just by cases initially. When we looked at the digital divide, the individuals in North City were disproportionately impacted. And just to, again, allow you to scale this in your mind. So we had over 70,000 individuals register using our COVID-19 vaccination survey. And only roughly 2,200 of those were in North City, covering all zip codes in North City. And so the digital divide is very real. And so although we pivoted, we also we kept in mind the root causes of what's happening in the city of St. Louis. So the disparities that we talk about, the inequities that we're seeing during COVID, they're not new. None of this is new. We saw this in H1N1. They saw this back in 1918. These outcomes are not new. And so it really, I don't say it irritates me a little bit, but it does irritate me when we go through these public health experiences and because of politics, everything is treated as if it's new. What we have to recognize is that none of this is new. We've seen this before. And in order for us to really get through this, we have to look at it differently. We can't continue to silo the demographic information. We can't continue to silo these different risk factors and only look at those risk factors, but we really have to look at how the systems operate. And that's what the intersectionality analysis will help us do. Understand how the systems, interlocking systems, work together to continue these efforts of oppression for certain populations. Again, disadvantaging some populations while providing advantage to others. And that in itself is an injustice, especially when we're receiving additional federal funds to actually make the necessary improvements. As I tell my staff, we just focus on COVID-19 and forget about the root causes of inequities and disparities. That in itself is an injustice. And so we can't come out of this better if we're only focusing on COVID-19. And so we're looking at the systemic causes of these inequities. We understand COVID-19 is there. It's another illness that's spread by respiratory transmission, and we have to call it that. But we also have to be mindful of these core issues that we can't just gloss over because of politics or personal gain.
Thanks so much. And there are a couple of other questions in the chat, and I'm going to get to those in just a second, but I kind of want to touch on this since you're talking about intersectionality. And I think, you know, I started in public health practice at a local health department in Colorado a couple of decades ago. And I've seen in practice and in education that we've come a long way about thinking about public health, not just being about behavioral change, but about policies and about systems and how systems of oppression are, you know, predict unequal health outcomes. And so I just want to kind of get your thought on how you're doing that work in the health department to get everyone on board with that as well, because it takes a lot of organizational and individual journeys to get to that. And I'm just wondering what you do within the health department to get staff on board.
So one, being able to have open dialogue and creating a safe space for staff. So when you talk about oppression, when you talk about racism and the systems that can create tension even among public health staff, because we all have our different experiences, our lived experiences are very different, and we bring our baggage to the health department. And so one of the things that I did when I first started was I started meeting with my executive leadership team. Started having these difficult discussions with the executive leadership team, and knowing that the health department wasn't equipped to handle these types of discussions on its own, we partnered with an organization called the People's Institute. The People's Institute, they hold this training called Undoing Racism. And the goal of this training is to really shine a light on how systems work. So it shows the macro and micro level of systems and how if we don't, and it also allows us to learn, you know, if we don't understand the system, we become part of the system. And then we become the part of the problem. And so work with my staff so that we can do the work internally. Because unless we do the work internally, there's no way we can really address the issues that are out in our community. And so looking at really putting the mirror on the health department and having us work with the facilitator that has experience having these discussions and getting individuals through these types of trainings was really important for us. And so that was the first step. And then the next part is just making sure that health equity and health justice is integrated into every program. So, you know, some health departments have a health equity program, they have a health justice program, a racial justice or racial equity program, but that's not sufficient. That should be integrated into the fabric of every program in the department. And so that's exactly what we're doing. And so we actually, at the start of my tenure, we had a program called the Health Equity Program, but we'll be dissolving that program again, because every manager, every staff, whether you're an executive leader in an executive leadership position, or if you're a frontline staff, you have a role in health equity. And so, and that's the culture we're creating here at the health department, because not just because it's the right thing to do, but it is the right thing to do, but our community deserves better. When we look at the data, when we look at the reports that have been issued for the last 10 years, the trends are there. You can almost expect the same outcome every year. And one of the things that I looked at when I was in the county was the STI report. So you can almost, for the last 10 years or so, every year you could just say St. Louis City was #1 for gonorrhea, chlamydia, and even syphilis in some cases. And so how do we get to a point where we normalize that data? That's exactly what happened. People just we came to expect it rather than say, okay, this is not acceptable. How do we address this? And so by implementing an equity and justice approach, we've been able to make some strides. But again, looking more deeply at how the systems are helping create this narrative is really important. So having the intersectionality analysis and is going to help us moving forward.
Great. Yeah, thank you so much. That's really insightful. Thank you for your work on that too. And there are a couple of questions, and Victoria, I see your question, but since we're kind of on this topic, I will stick with it and then we'll come back to yours. But Carolyn is asking about intersectionality in terms of implementation of programs. So for example, public health working with other departments like education, economic development, and housing. How do we do that to address the intersectional problems?
And that's a great question. So one of the things that we have recently looked at, so starting in July of last year, I started meeting with the government services analysts for the health department, who's a policy staff, and we started having discussions about how do we change the legislative process to make sure that we not force individuals, but we encourage individuals to understand the impact that legislation will have on different populations across the city of St. Louis. And so if you're proposing legislation, how will that impact minority communities or non-minority communities? What impact would that have on the economy of a particular jurisdiction? And so we just submitted a proposal to the Kellogg Foundation, which we hope will be awarded. And the goal there is to make sure that we have a justice approach for legislation. So ideally, we would like to have each piece of legislation accompanied by a racial equity impacts assessment. Again, this is for every piece of legislation that's drafted. And then in addition to that, we also want to make sure there's a shared knowledge about anti-racism, health justice amongst the appointed officials, elected officials, management across city agencies, as well as frontline staff. So there's a shared understanding about what racism is, how it operates, how it functions, and also, again, going back to the systems, learning how the systems operate. And so there's a shared knowledge across the city of St. Louis. We can do a better job of protecting our residents from those unintended consequences that can lead to harm or worsened health outcomes for a certain population. But unless we're paying attention to our population and getting feedback from the community, we won't know that. And so it's always, we seem like it's always easier to draft legislation or to draft policies without the input of others. But then when those communities are impacted, who's left to clean up the mess? The health department. So we want to do a lot of the work on the front end. So we're proactive about making sure that we protect the health of our residents. Overall, the city of St. Louis and surrounding jurisdictions will be much better off.
Great, thank you so much. And I think that does kind of lead into the other question, and I want to say $1 million question, but maybe we'll call it the $1 trillion question. So with lessons from COVID, what critical public health infrastructure is needed moving forward?
That is $1 trillion question. For public health investment, and that's really the key. So in the state of Missouri, so I think everyone on this call, in this meeting may be familiar with this, but per capita, the state of Missouri spent less than any other state in the United States, in the continental US, on public health. That says a lot. And so when we look at the infrastructure that was in place before COVID-19, we really shouldn't be surprised at the disparity of what we saw, the impact of COVID. Because if we look at other reportable conditions and other public health issues, we're really in a dire state. So how do we get beyond this dire state? The only way we can do that is by proper investment. And so we need proper investment in the public health system. But even within the public health system, we have to make sure that our workforce is properly trained and developed so that they can really do this critical work that we are charged to do. And we have a role to play in that as well. So as a physician, as a educator, as a public health professional, our primary role is to educate and inform. That's how we empower the community. And so the health department is really doing a better job of going out and being present in the community, but not just being present in a way that we are genuinely engaging individuals, especially our most vulnerable populations, but then taking it a step further, not only engaging them, but also giving our residents an opportunity to provide input to public health programs. Because no one understands the community's plight other than individuals that are going through the particular situations, right? And so if we don't ever give them an opportunity to share their experience with us, then that's even worse, because that means we're bringing them to the table, but we're putting them on mute because we're not listening to them. So when we engage them, we have to not only give them a platform, but we have to listen. So we started working with our communication teams, communication partners, to have focus groups so that we can hear from the community about what they're experiencing and what their true issues are. And that way we can make better decisions about our initiatives, and that's also important so that to ensure that we are not causing additional harm to the community that we're charged to protect.
Yeah, thank you. And I think we have a few more minutes. We have a few more questions and comments in the chat, but I also want to just encourage anybody in the audience, if you'd like to take yourself off mute to ask your question, please feel free to do that. Otherwise, I'll move on with Claire's question. She asks in the chat, you mentioned the staffing issue that you have experienced, and they're wondering if you if or how the city residency requirement for employees has impacted your work this past year.
So that's a good question. So what we've done is I was an advocate for the health department, so making sure that we were able to bring on additional positions, and so we've fared pretty well as far as being able to hire really good staff. So I mean, we've hired epidemiologists, disease investigators, environmental health workers, even during the pandemic, and we've been able to really recruit a high caliber group of public health professionals. And so because of my advocacy, I guess I have to take credit for that. We've been able to fill positions even during the pandemic, even with the economic downturn that the city experienced. But even beyond that, so one of the things that we are also adamant about is making sure that we have strong partnerships with academic institutions. Learning public health in school is very different from public health practice. So we can talk about intersectionality, we can talk about systems level change in the classroom, and that sounds great. It's inspiring. But when you're out and you're actually going against the grain, you're going against the wave, you're moving against the tide in a lot of areas, it can be very disheartening. But my goal is to make sure that, one, I protect my staff from the politics of the work, and so that they can really enjoy doing public health. Then also support them and mentor them and coach them along the way, because they're really the future of public health. And so whoever's coming behind me, I want them to be as equipped as I was when I started, or even better equipped. And so if I can use every opportunity that I can use to mentor my staff and coach my staff, even our newer staff, I do that. And
Great. Yeah, thank you so much. And with just a couple more minutes, I want to be sure that we give you appropriate thanks for your time here today. We really appreciate your leadership and your work in the city of St. Louis. And maybe just one final word of advice that you have for our MPH students who will be embarking on their public health career here in the next few months or next year or so. Any sage wisdom that you can pass on to them as they do that?
The one piece of advice that I was given early on was to determine what you want your legacy to be. each of us, we have one life to live. We have which is finite. But with our time on Earth, what do you want to do? What do you want people to remember you for? Is it being political? Is it being a change agent? Is it being a community advocate? Is it really being an advocate for systems level change? What do you want your legacy to be? And so once you find out once you determine what you want your legacy to be, stick to it. There's a lot of support, and it's not easy always. I'll say that it's not easy always, but if you know exactly what you want your legacy to be, stick to that. And make sure you surround yourself by people who support you. That's also really important. Beyond the academic sector, when you get into public health practice, that can be your saving grace. And so relationships are really important. But again, you want to make sure you have the right people in your circle, so that as you move forward and you create the legacy that you want to create for yourself, you have the right people. You have the right people by your side.
Great, that's excellent. Well, I think with that, we will end our session for today. Again, thank you so much. There's a lot of comments of thanks in the chat. So I know everyone appreciated your time and expertise here, and we wish you well. And thank you so much again for being here with us today.
Thank you.
Thanks, everyone.